on the y-axis you have drug effect, and on the x-axis you have drug concentration. Then you have two designations, an EC50 and an Emax. So Emax is the ultimate or the maximum efficacy of a drug. So usually that will determine, when we get into talking about drugs, we'll talk about dosing ranges. And with a range, there's usually a starting dose and there is a maximum dose. I'm putting this into context. You don't have to write this down. I'll keep coming back to it over as we talk about drugs. But you see that when you give a drug, eventually it's going to tail off or plateau. So beyond a certain point, you cannot get any more effect out of the drug. There are a few what we call high ceiling drugs where we can just keep dosing, but most drugs are not that way. Most of them reach a point where if you keep giving more drug, you don't get any more effect. What you usually will get is more adverse effect. So that usually that plateau starts to tell us where our maximum dose is. The EC50 is where you're getting 50% of the effect. And you see that on that line, that it is actually not the halfway mark of the dosing. So I'm going to tell you this, and I'll tell it to you again. You do not have to write it down if you don't want. Just kind of listen and follow my thinking. What you see is that usually, initially, you get the biggest bang for your buck at the lower end of the dosing range of a drug, or when you get to about midway point through a dosing. So let's say you have a drug and the starting dose is 10 milligrams a day and the max is 40. So at about maybe 20, you're going to see probably 80% of your response. And as you go up further, you'll get some more effect, but you won't get as much, or you won't get a doubling of effect. Okay? And that's because that hyperbolic relationship that you're seeing with this, it's not a linear straight line where it would be proportionally more and more and more the more you raise the dose. Okay? So that's an important thing that we will keep coming back to, and you'll see it again and again as we talk about drugs. So usually you'll get the most effect when you are at the lower end towards about halfway through a range of dose. Okay. This other B talks about receptor-bound drug is on the y-axis, and the drug concentration is on the x-axis. So I hope you'll start to appreciate how incredibly a miracle it is that we can get a drug from our mouth to a receptor and get an effect. We know that because we take drugs and we expect them to do what they are going to do, or they've been touted to do. But to get a drug to through the gut, the system, into the bloodstream, deliver it to an area of the body where it can then exit the bloodstream, get into the extracellular fluid, and then to a receptor on the cell membrane. It's an amazing journey. And in that, there is an equilibrium that gets established between the amount of drug that's in that outside the cell and that receptor. Okay? So, and that receptor will have a certain affinity for the drug. So there can be a lot of drug, but if there's not a great affinity, then we don't get a great effect. At some point, we max out all those receptors. So we can get more drug, but we're not going to get more effect because there's not enough receptors to accommodate all the drug that's there. So that KD is a dissociation constant, which means the lower it is, the greater the affinity of that receptor for that drug. So there's a limit. So that we'll start to see that when we're using drugs is that we can't get any more out of it. Or somebody will respond at very low doses, but as we go up, even though we would expect more, we don't get it anymore. It's because their receptors maybe are limited, or their affinity constant is just not what we had anticipated. Questions about this? Okay. So let's talk about a few things, agonist and antagonist. So when we make a drug, we are usually making it to fit on a receptor at a point where if we want it to do what the endogenous or the things that the body makes, if we want it to replicate that, then we call it an agonist. Because when it sits on that receptor, it evokes a response that's just like what an endogenous substance would do. So when we give insulin and it sits on that insulin receptor, we expect it to do exactly what the insulin you produce does. Okay, that's an agonist. So agonists have different, because they are not exactly like the substance you make, it may or may not evoke the same response to the same degree. So we do have partial agonists. So again, here we are back to a dose-response curve. So you've got activity on the y-axis, concentration of the drug on the x-axis. So a full agonist, or a drug that's just like what we are making, this would be the expected response with this effectiveness. A partial then is not going to be able to attain that same amount. It has a similar response curve, but the efficacy is much lower. What about antagonists? So antagonists we use to block or change the effect that an agonist would have. So just like an antagonist in a book or a movie, an antagonist works against and tries to thwart the activity of the agonist. Now, they're a little bit more complex, a little bit more interesting molecules to look at. So there's several different types. We'll put them into 4 categories: competitive, non-competitive, chemical, and physical. So a competitive is just like it says. It competes with the same binding site on that receptor as the agonist. So that's why it's called competitive. Okay? It's usually a more weak effect. It usually doesn't last as long, and it can be overcome. I can give more drug, and I can get the effect. So a competitive antagonist can always be overcome. You just give more agonist. And that's what these little graphs are showing. So this is where you have the agonist alone. You give an antagonist, and you're moving that response to the right, and so you're not getting as much of the effect. But if you give more antagonists, you keep pushing it out. So so this one is we can keep giving more, but we're still going to get some effect because we're not going to get a total block. Non-competitive are a little bit more powerful. They usually sit on the receptor at a different site. But that different site is so powerful that it can keep the agonist from, even if it sits in its receptor site, it can evoke a response. These are insurmountable. They're usually longer acting. I can give more agonists, but I'm not going to get the effect. So this first line shows you in the absence of an antagonist, that's what the substance would do. As we give more and more antagonists, we lower and lower the effectiveness of the endogenous drug or the endogenous agonist. Questions about that? Chemical antagonists, pretty straightforward. They bind the agonist. They just deactivate it. So that's like if you take an antacid, you bind up the acid and it can't do its job. A physiologic antagonist is a drug that has an opposite effect. It doesn't sit on the receptor, doesn't do anything to the agonist itself. It works through a different mechanism to overcome what the agonist has done. So the example I've given you is glucagon and insulin. So insulin drives blood sugar down. What we're going to use as a physical antagonist is we're going to use glucagon, a different hormone that can go by a different route and stimulate the liver to put out more sugar and overcome a low. So we didn't do anything to insulin. We didn't sit on its receptor. We didn't bind it up or interfere with it. We just use a different mechanism that the body has to raise blood sugar. Questions about those? Okay, let's talk about drug dose. So let's talk about potency and efficacy. Because we throw those terms around, but it does have a specific meaning. So potency it's really a relative term or a comparative term. If we only have one drug, we don't care how potent it is because it just is what it is. But like when we get into steroids, we'll talk about their potency and how much drug it takes to evoke an effect. So a drug that's very potent, it takes just a little bit to do what we want it to do. Okay? So the very high potency steroids, it just takes a smidgen to get an anti-inflammatory effect. Whereas you can go out and buy hydrocortisone over the counter, and it's a very low potency steroid. It takes a lot to do what you want it to do, even though it's still effective. So here on this graph, A is the most potent drug. The smallest amount gets the effect. And as we move to the left, we see higher potency, where D is a lower potency drug. Still effective, it just takes a lot more to do it. So when people look at a drug and go, man, you gave me 500 milligrams of that, that must be really potent because that other drug you gave me only had 10. It doesn't have anything to do with it, nothing. Okay. So the strength of a drug just tells you that's what it takes to get the effect you want, but it doesn't speak to potency. Okay, then there's efficacy. Does the drug do what we want it to do? So maximal efficacy reflects the limit of the dose-response curve. Usually it's related to receptor interaction or concentration at that point. So in this one, drug A is the most effective and B is the least effective. I think I caught this as an error. Does yours say B? Okay, it's D. I caught it last night as I was going through. So A is the most efficacious, D is the least efficacious. And that's by that max, where that starts to plateau out. These would become more important when you're getting into looking at what drug you are going to treat a specific problem. So we would look at efficacy in terms of those. We really always want to go with the most efficacious drug. But the most efficacious may have side effects or may not work for a particular patient for whatever reason. Many patient factors come into play. So efficacy usually comes into play when we first start. Where are we going to choose? We want the most efficacious, and then based on patient response or patient factors, we may have to choose a lower efficacy drug. Dose response curves, I think I may have just beat this one, but this one is, again, dose response curve. Usually you've got the dose of the drug on the x-axis, and on the y-axis you have the drug effect. But let's talk about therapeutic window. This is an important concept. So therapeutic window means what range of dosing can we do in a drug that will give us a minimal effect and maximum effect and the least amount of side effects. Anytime we use a drug, we are always balancing. We always want the good to outweigh the bad. We would never give a drug where the bad outweighs the good. We just wouldn't do it. There's no reason to do it. So it's always benefit versus adverse event. So with some drugs, we won't tolerate a real close benefit to risk ratio. Cancer drugs will accept a lot of risk to get a high benefit, saving the person or extending their life. So it's always that balance. So here's where therapeutic window comes into play. So plasma concentration on y-axis, time is on your x-axis. So we give a drug, it goes, if we give it orally, then we have to wait for it to get absorbed, get into the bloodstream, get distributed, and then it starts to rise, the concentration starts to rise, and we start to get an effect. At some point, we get a peak effect where maximum amount of receptors are engaged and the drug's doing what it's supposed to do. We also call that C max, or the maximum concentration usually of a drug. That's important because usually that's when most effect occurs, also when most adverse effect occurs. So a couple hours after you take an ACE inhibitor for blood pressure lowering, you get the lowest blood pressure effect. Patients may complain at that point. Oh, I feel dizzy, I just don't feel good at that time. Well, it's usually you got that maximum effect and then it starts to tail off like you see here. And so it will tail off until we get back down to that minimal response. So the window is from the minimal point where we get a desired response to where adverse response would start to outweigh the effect we're getting. That's the therapeutic window. Below that, we call it subtherapeutic. We're below what the amount that will give us an effect. And then the duration of action is between that, from minimum to minimum. So we'll talk about that. Duration of effect usually will help us start to determine how frequently we give a drug. This becomes really important when we get to antibiotics. Because with antibiotics, we've got to have a certain concentration maintained for a certain period of time to kill off the bacteria. It'll also come into play a lot when we talk about anticonvulsants, because we want it to stay in a certain range to keep them from seizing, but we don't want it to go too high to give adverse effects, which are usually can be fairly significant. Questions about therapeutic window? And last is therapeutic index. Therapeutic index is kind of like therapeutic window, but just a little bit different. Therapeutic index, again, is the minimum to the maximum. Minimum effect and the high point where we start to see adverse effects happen. Drugs that have very narrow therapeutic index means that they're where you get the effect you want and where toxicity shows up is just right next to each other. Those drugs usually require a lot of monitoring. We will sample the amount of drug in the blood. Digoxin would be one of these. We don't use them very much anymore. Usually once we have those drugs, you'll see manufacturers start to move towards drugs that have wider therapeutic index because they're expensive and the inner variability of patients will make it more difficult to use those drugs without a lot of oversight. So we want drugs that have wide therapeutic windows. We want where we get a desire or the desired effect and where that drug starts to cause adverse or toxicity, then we want that to be really far apart. Okay, questions about therapeutic index? Yeah.
What does TD50 mean?
Oh, those are like where toxicity, the 50% where the toxicity, lethal concentration would be. Yes?
So does a wide or narrow therapeutic index also mean the same thing as the window?
No, they're a little bit differently. It comes how the index is a ratio between the TD50 and the ED50. So that's how that's determined. It'll have a number, but we usually don't even worry about, we just talk about narrow and wide. But the index is actually a ratio. And it's based on that TD50, which I didn't spend much time on. Does that make sense? So the window looks more at concentration, serum concentrations, or dosing, or the kinetics of the drug going through absorption to elimination. So a little bit different concept. Okay, any questions about this? So that ends the material that's going to be on the test on Friday. Say it again.
Just to clarify, this will be on our next text block then?
Monday, Friday.
This will be on this
That
coming.
ends up what will be on Friday.
Okay. Wait, make sure, right.
Yeah, it's two, I just have two, it's the,
So not this one.
yes, that's my understanding.
Woo! And so this is on our next text block, not the coming one.
No, what I have, everything I have stood up and gone over from last week and this week, that's it.
So like the intro.
Yes.
And then drug chapters.
Yes, 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 that's my understanding.
Well, we thank you very much for that.
Well, no, I don't set that up, that's Professor Torres set that up.
So, and the high points, like the objectives, is what we want to focus on for
Focus on the
questions.
objectives. Where's Madison? Who sent me the note? Okay, so I tried to, if you all send me questions, I usually, if they have broad implications, I will broadcast them back to the class. So just keep that in mind when you ask me something. I will send it back out. So I changed that objective. It was on the foremost common errors with, I don't remember now what the original was. Medication safety, yes. Okay, now we're going to move on to kinetics. Okay, do you have that material up in front of you? It came last night, should have seen it last night. Okay, just as a way to keep making me human, this is just sharing a little bit with you. You've met my husband, Mark Britton. We don't have the same last name. It can take students years, or a couple of years to figure it out, so I'm just telling you up front. This is my husband, Mark Britton. This is my son, Cameron. He is a first-year medical student at OU, and this is his lovely wife. They got married over the summer. Her name's Anna Claire, and she is a nurse an ICU nurse at Deaconess. We share a house with many animals. These are our dogs and our little cat. Our cat is about 4 months old. Her name is, the dog's named her. Her name is LT2, which is Lieutenant Tiny Terror. She is the smallest in the house, but she terrorizes the dogs. This is our 80-pound baby, and he is a baby. Schultz. This is our Sheltie, Sammy, and our Australian cattle dog, and the most grumpy of all is Pepper. So that's our family. Okay. So today we're going to talk about these topics under kinetics: the absorption, bioavailability, distribution, metabolism, or biotransformation. Elimination of drugs or excretion would be another word. Steady state, half-life, linear, nonlinear kinetics, and dosage forms. And these, I think, are in test block 2. I will verify with that. I'm counting on you all more to know that, but that's my understanding. But your blocks are a little bit different, so instead of having discrete classes. And as far as I know, I have 10 questions on, that's what I submitted on the test block for Friday. It is 5 from each lecture, and it is 5 from each lecture. Yes.
And that.
I'll verify and send you out an email just so you don't have to hang over. Okay, what are kinetics? You can kind of take it from the word. So kinetics is movement. So it's really the movement of drugs throughout the body. So it's the study of the absorption, distribution, metabolism, and excretion of drugs. You'll often see it denoted as ADME. That's just shorthand for it, and a lot of people use it. We use this in order to individualize or design an individualized dosage regimen that optimizes therapeutic response of a medication while minimizing the chance of adverse drug reaction. That's the whole goal of using drugs, benefit versus risk. Pharmacokinetics deals with the dose concentration part of the dose effect relationship. So the dose and concentration of a drug related around that drug receptor complex or interaction. Just to kind of keep in mind, pharmacodynamics is the relationship of the drug concentration and the pharmacologic response. So pharmacodynamics is always dealing with response. Just to remind, we talked about this probably last week. Drug receptor complex, pharmacologic effect is related to the concentration and accessibility of the drug to a receptor. The time course of drug access to a receptor influences the time course of drug activity. So the longer it has access, the longer the activity can go on. So the more concentration at the receptor, the longer it's available, the stronger and longer lasting the effects. And also the possibility for toxicity. Okay, so I want to introduce this concept, and we'll come back to it. So we talked about therapeutic range, the points between minimum effective concentration, the MEC, and the maximum safe is your therapeutic window. And that also we translate, and we'll talk about more. We don't talk about windows so much as we will talk about range. Here's the range of dosing. Here's the range that we can use and stay within that. You'll often see it referred to as the recommended. So when a drug goes through all those processes to be approved, they will come up at the end, they will be approved for a drug to be used within a dosing range. There'll be a minimum, there'll be a maximum. Okay? You go beyond that and you risk a more adverse effect, and you risk having to defend that if something should happen to a patient. The other concept to add in is steady state. So when we give a drug, right here, initial dose, we get a rise in the concentration, and then as the body gets rid of it, it falls off. If we dose it again before that drug can come, the amount in the body can come back to zero, see what happens? Our starting point changes. We start from here, we give the same dose, we get a rise, we get the same rise, but it now leads to a higher plasma concentration. And it falls again as it's eliminated from the body, but we're going to dose it again before it can fall any further. And we're going, again, we got a new starting point. Drug rises the same amount, but we get a higher plasma concentration. It falls off. Again, we dose it again, and we get another rise. So what do you see at this point? Pardon? It's a plateau. So now we've reached the point where our dose coming in and our dose going out has reached a steady state. And that's what we call it, steady state. And that's what we're always trying to achieve. This is very consistent with medications. So we're going to call that the steady state, equilibrium. We're going to talk more about it as we go through, but I want to introduce that at this point, and we'll come back to it. Just to go back to narrow and wide therapeutic windows. Wide therapeutic windows gives us a lot of leeway. Makes it really safe for patients to take a drug. It also really accommodates interpatient variation in elimination or effect or receptor concentration. Narrow therapeutic windows don't give us as much leeway. We see much more toxicity. Patient factor effects will also contribute to that. Okay, so drug disposition. Again, depending on how we get the drug into the body, may alter this somewhat. But we are we're reliant on the drug getting absorbed, getting it into the bloodstream. And then once it's in the bloodstream, if we think about bloodstream being like a highway or transportation system, it's just it's a carrier for what we want, and it then drops off or distributes drugs at a certain point. Usually at a capillary, drugs can exit, and interact then with a tissue where those receptors are. Okay. In the bloodstream, a lot of times the carrier is a protein. So drugs bind to almost anything. So there are proteins, so you'll have protein bound and free. So an equilibrium sets up in the bloodstream between what is free drug, unbound drug, and bound drug to plasma proteins. The drug exits the bloodstream, and again, it goes into another equilibrium, bound drug and free drug. Bound to a receptor, not bound to a receptor. Coming off of this, we have two mechanisms that are trying to get rid of that drug. One is biotransformation or metabolism. The body is geared towards getting rid of what's foreign. So the liver and other organs can change that drug so that it's more likely to be eliminated and the body can get rid of it. So in competition with what the amount that's in that bloodstream is, we have drug that's being pulled out and metabolized into what we call metabolites, which are more effectively can be eliminated. And I'll talk about that mechanism in just a bit. And then we also have drugs that are being eliminated. Body's getting rid of it. So all of those dynamics are going on at the point when we put a drug in the body, and we're just trying to get an effect. But we've got all these things that are going on. So the sum total of what a drug can do is based on all of these actions that are going on at the time. Okay, so let's talk about absorption. So, and we'll go from oral first, absorption instead of something given IV. So when a drug gets into we swallow it, gets to the stomach, then moves into the intestines. The intestines then are going to move it through those microvilli and get it eventually into an interstitial space and then the bloodstream. Many, many layers that it has to go through. So you can see why drugs fail as they go through. Sometimes it's just this point, can't get it out of the stomach or out of the GI tract. Oops. This is just another rendering of that same concept. So this shows vitamin B12 coming in, complexing with in the stomach, and then moving through the intestines. Has to bind to that receptor, a receptor in the gut, and then move again through that interstitial space into the bloodstream. So just another way to look at it. I like this drawing because it brings up the dissolution requirement for a drug. So when we give it in oral form, it's got to break down. It has to dissolve at some point. Usually that is going to take place in the stomach. So that dissolution, so if we're really dependent on the pH to be part of that dissolution factor, if we mess around with the pH, it could change the ability of that drug to dissolve. We can also create dosage forms that will bypass some of these processes in the gut and get it to dissolve at a very different point, maybe in the small intestines. So we can use this knowledge of how usually a drug will go into solution to help us in getting past some of the side effects. A lot of drugs upset the stomach. So if we can get them past the stomach to dissolve, they don't bother. When you get into the small intestine, it doesn't seem to bother people as much. So when we talk about enteric-coated products, what we're usually trying to do is get past the stomach, because aspirin's a common one that we put an enteric coating on it so that it won't dissolve in the stomach. Because when it does, it's a very acidic drug and it's very caustic and it causes upset stomach. So if we can change the nature of when that dissolution occurs, we can get people around that stomach upset and potentially the bleeding that can come with it. And then this just shows the same thing we talked about in those other pictures. You getting into the stomach, the small intestines, microvilli complex is going to, and very well vascularized, going to allow drug to move then into the bloodstream, which is where we want to go. So absorption is from the point of entry, wherever that is, to the point that it gets into the bloodstream. That's absorption. That can be quick, it can be slow. We can design drugs so they dissolve very quickly and we get good effect, or we can do it to where it is very slowly absorbed and we get prolonged effects. So we can think about direct absorption being where we put it right into the bloodstream. So if we give something IV, it's directly gone into the bloodstream, right? Or we can think about intrathecal. That's where we put it right into the spinal fluid, like in this picture, where we want the effect. So those are direct. Most drugs we give are indirect. So, and this shows you some of them. This is sublingual, we put it under the tongue. Usually that's pretty fast absorption. Or we can do buccal, between the cheek and gum. Or we can have people inhale drug. Or we can put a drug into a patch and let it absorb through the skin. Or we can give it IM or sub-Q. Usually things are designed, the reason why all of these are designed is to get around something that is causing the drug from being able to act. Okay. So patches came up because they get around the liver in terms of metabolizing the drug real quickly, and they're absorbed over a long period of time. So all these designs come in order to address some problem that has come about because of that ADME. Questions to this point, or comments? Okay, so factors that can affect a absorption. Just formulating the drug itself. When you look at a tablet, it's got lots of stuff in there. You got binders, you got vehicles, excipients we call, you've got maybe a coloring that's been added. So the formulation itself can be a problem, can interfere, or change the way that a drug is absorbed. But on the other hand, we use it to our advantage. So we can get things to rapidly absorb, usually like melts or lozenges. Those are can be very quickly absorbed. Liquids, very quickly absorbed. Body doesn't have to do much to it. It's already in an alcohol, it goes kind of very quickly to the small intestines and gets absorbed rapidly. Or we can make an extended release product. We can make it so that it so slowly absorbs that we can make it to where you don't have to take the drug once a day. We can even put little osmotic pumps in a drug that use osmosis as a way to get that drug to leach out over long periods of time. We can put it in a matrix that also will hold it, like a wax matrix, that will hold that drug so that it isn't so rapidly disintegrated and absorbed. It's wonderful. People make their living off this. So pharmaceutics is kind of the science that deals with formulations and how to deliver drugs. Biophysical properties of the drug. So large drugs we have trouble with because they can't exit the bloodstream as well. Lipophilic drugs tend to have a really easy time to get into a cell. So hydrophobic, lipophilic, we use those to our advantages, or we have to work around them. Acid-base properties of the drug. The insulin lantus actually has a pH of 4. When you put it into tissue, which has a pH of 7, it precipitates out. Well, we use that to our advantage because then it will slowly absorb out of that precipitate over a 24-hour period. Whereas when we give an insulin like Apidra, you put it into an injection site and in 15 minutes you have insulin into a bloodstream. Okay? So the wonderful world of chemistry, we have used it to our advantage and to help extend the range of possibilities in treating patients. So we need to talk about bioavailability because I've talked about all the barriers and the miracle of getting a drug from the point of entry to the bloodstream. So bioavailability is a term that we use to talk about how available is that drug to the organism. So the extent of drug entry into systemic circulation, so systemic means past the liver. Because systemic means then it becomes available to all the body. So when you take a drug into the gut, what drains the gut? What part of our vascular system drains the gut? Where does it go?
Portal system and the cable system spots.
Mesenteric, all those. Okay, so good. So portal, so a lot of what the gut absorbs first, it goes through the portal system, and where does that, what organ does it hit first? Liver. Okay. The liver, one of its big jobs is to clear things or to change things so that it is less toxic to us. So it has a big job of trying to keep those things out that we ingest from harming us. So when those drugs are absorbed, they're actually going to go through the liver first. The liver can do a lot of changes to that drug before we can ever deliver it then to the rest of the body. Okay. So backing up, for bioavailability, we always, it's a percent. So bioavailability is expressed as a percent. And it's all, the reference standard is IV. So if we give it IV, it's 100% available. But through other routes, it becomes less available. So here is just a comparative. So here's IV, 100%. IM, quite a bit less. Here's a tablet, quite a bit less. Here's a suppository, a lot less. Here's a tablet, a lot less. Okay. And you see that there's also a change in like the peak or the absorption rate of those drugs as well. Okay. So this is our standard. So just like we said, that let's say that a drug is said to be 10% of bioavailable. Well, that means we gave 100% of the dose. It had to move through the gut, got absorbed, portal system picked it up, took it to the liver, and the liver metabolized most of it, changed it in a way that it was no longer active. And 10% of it made it out to the systemic circulation. Okay. It doesn't matter. If that percent is enough to be effective, it doesn't matter. We give drugs, there's a drug, Zocor, it's a drug to lower cholesterol. It is 5% bioavailable. Doesn't matter, it still works. Where it becomes trouble is when we change that bioavailability. If we give it with another drug that inhibits the liver's ability to transform it, then we get a lot more drug. So if your patients take their Zocor with some grapefruit juice in the morning, grapefruit juice knocks out some of those ability of the liver to metabolize that drug as fast. Then we get a lot more drug into, we can get a 15% bioavailability. Well, that much drug can cause a lot of problems. It can damage muscle and damage enough muscle to lead to acute renal failure, and the patient has to be admitted to the hospital. So that's where this will become important. So don't be shocked when you see, oh my gosh, we give that much drug and we only get that return. Doesn't matter. If that amount of return gets the effect that we want, doesn't matter how much we get past. But when we start messing with it, or we change it, that's where we're going to see side effects, or we can see no effect of the drug at all. The rate of bioavailability is the speed at which a drug is available to systemic circulation. It can be rapid, and that would be usually drugs that really quickly can be absorbed, or like an IV. IV would be very rapid. Moderate, usually most of our tablets are going to be rapid. Moderate. An inhaler. When we give, when a kid uses an inhaler for acute asthma symptoms, that's rapid. We can get it to the source or the point of action very quickly. Slow are usually those extended release products, or a transdermal products usually are very slow. Okay. Questions about bioavailability and absorption? Lots of patient factors, lots of drug interactions occur at those points. You can't give some drugs with an antacid because the antacid will bind up the drug. Okay, that would be an example. Okay, so once we get the drug into the bloodstream, then it will distribute. And it will go all over the body. We can control it with some things, but the garden variety of drugs are not going to be that controllable in terms of where they distribute. So they go into the blood, but they will also enter tissue, and the tissues will bind them to differing degrees. The liver's going to try to get rid of them, and the liver also changes them so that the kidneys can even get rid of them faster. So let's talk about the metabolism or biotransformation part. So metabolism is the chemical conversion of a drug, usually through an enzyme-mediated system, into another chemical entity, and we call that chemical entity the metabolite. We call the drug that we give the parent drug. We call the drug that we call what it is changed into, usually by the liver, but it can be by other organs, the metabolite. Metabolites can have usually metabolites are less active, less effective than the parent drug. Not always, but usually. So they can be totally inactivated, or they can have a small percent of, or they can have some degree of activity. Usually, well, I'll get ahead of myself. Sometimes a metabolite will be much more effective. And there are some drugs, there's a drug for gout, allopurinol. It gets, its major metabolite is called cameronone, and cameronone is the active part. And its activity is 24 hours, whereas the parent drug, in a few minutes. So we don't get as much activity on the parent drug. So we take advantage of that. Most metabolism will occur in the liver, but all organs have some degree of metabolic capacity. The gut does, the lungs do, the kidney does to a small extent. The brain has some ability to metabolize drugs. But the power horse is the liver. Okay, so we talked about that those drugs, mostly not IV drugs, have to go through the liver first. And that the liver can extract a great deal amount of drug and metabolize it and never reach systemic circulation. We have a name for that. We call it first pass effect. So the first pass through the liver, a great amount, whatever percent of drug is extracted, that's called first pass. Some drugs are so inactivated by the liver that we can't even give them in that form. So estradiol is one of those. So the predominant female hormone estradiol, if we give it orally, the liver will absolutely destroy all of it or metabolize all of it before it got to systemic circulation. So what do the chemists do? They just stick a big ethynyl group on that estradiol, and the liver cannot metabolize it to a great extent quickly. Okay. So we can manipulate the molecular structure of drugs by usually putting some type of inert molecular entity on it and change the metabolic compound. So drugs that have high first pass effects, usually we cannot give orally, or we have to change them in some way. A lot of this will depend on the affinity that the drug has, that the liver has for that drug, and its capacity to metabolize it. Okay, questions about that? I'm looking at whether to take a break now or to finish up this. Okay, let's take a break here, and we'll start back at 9.